But as many of you might have had these thoughts of feeling either concerned, exhausted, overwhelmed, or embarrassed to talk about certain bladder control problems. And it's a real issue. About almost half the people who have some sort of bladder problems are just afraid to talk to a doctor about it, or even to their family about it. This often prevents people from getting the help that they need, and our hope is that we can help you through that and get you doing better. So what we're going to do today is we're going to kind of talk about just a little bit of basic understanding about what controlling the bladder is. We'll talk more about overactive bladder in particular, and then some of the treatment options about this, specifically looking at Medtronic interstem or neuromodulation system, and I'll talk to you about that a little bit more. And for a full disclosure, I do not have any financial disclosures to announce. We're just talking about different therapies that we use and things that have been very effective for various patients of mine. So we're going to focus mostly on number 3, but there's really 3 common bladder control problems. So there's stress incontinence, urinary retention, and overactive bladder. So stress incontinence, which we're not really going to get into, that's kind of leaking when you sneeze, cough, laugh, when you're like bending over, getting up from sitting. And that's more common in women than in men. And there are things that we can do about that. So if you're here with that, this presentation is not really about that, but just know that there are things that can be done to help correct that and make that less of a bothersome thing in your life. Same thing with urinary retention, which is kind of the opposite. You can't pee at all. You're holding on to a bunch of urine, can't tell that your bladder's full, you can't empty your bladder all the way. You have a really weak stream, or sometimes in certain cases need to use a catheter in order to empty your bladder and drain your urine. So typically there are things that can be done about this as well. In very select cases, there are one of the therapies we're going to talk about today can work for this, but that would be something that we'd have to discover on a full workup here. But we're going to talk more about overactive bladder. So this is defined as frequent use of the urination, so frequently going to the bathroom, oftentimes having a constant urge to urinate that sometimes leads to leaks or urge incontinence. That's where you have the urge to go to the bathroom, you really got to pee, and you just can't get there in time, and a little bit or a lot of it comes out. There's oftentimes a lot of overlapping symptoms with overactive bladder and with some of these other things too, but it's our job to kind of work through these symptoms to help find the therapy that works best for you. This is a very, very common thing. As you can see here, over 1 in 6 adults in the United States have overactive bladder, men and women. So that's about 37 million people in the United States have overactive bladder. Now, some cases are going to be more severe than others, but this is more common than people with vision problems, more common than people who have diabetes in the United States. And this affects men and women of all ages, but does tend to get a little bit worse as you get older for the people who have this. And so there's things about this that we can do, and we'll get into that here. You might be asking yourself, like, if this is so common, how come I haven't heard about it until now? But the reason, as we touched on before, is that a lot of people are very embarrassed about this. They manage themselves by either just wearing pads, restricting social activities. A lot of primary care physicians, who's your main doctor, are often, they don't really realize how embarrassing this is to talk about this, and so they're often not discussing this at all with their patients. So if it's not asked about and you never bring it up, it likely stays hidden. So this is not something that you necessarily need to accept or ignore, because sometimes this could be something that could have a huge impact on your quality of life. So what is normal? What is not normal? So it's important to note that incontinence or leaking of urine is never a normal thing. Now, it's something that you can live with if you choose to, but it's something that is not what's supposed to happen. If some of these things sound familiar to you, they're going to the bathroom more than 8 times a day, getting that like really bad urgency, like I'm coming through the wall to go to the bathroom. If you have to plan your activity or plan a drive around where the bathrooms are, monitoring how much you drink or what you drink, or having to use pads, this is you might have overactive bladder if that's the case. So we're going to just talk about how that bladder control works. So normally in a normal system, the bladder and your bladder and your brain talk to one another. Your bladder starts filling up and it tells your brain, hey, I'm getting full. And your brain sends a signal down to the bladder saying, hey, it's okay, keep filling, you're not full yet. And eventually it keeps stimulating and it keeps getting stimulated as it fills with more and more urine. And it keeps telling the brain and giving all the signals to the brain, which eventually give it this permission to go to the bathroom. Now, for overactive bladder, basically what happens is that this crosstalk between the bladder and the brain goes away. We don't necessarily understand all the reasons why this happens, but there's a lot of research that suggests that a lot of these bladder control problems are linked to this, some sort of disruption in this pathway, so that the bladder is essentially talking to the spinal cord only, or talking to itself and not talking to your brain. And that's what can lead to these signals going haywire. So we'll kind of keep these points in mind for later in the talk when we discuss some of the various treatments. So where do these problems come from? There's a few potential causes for this. Some are as simple as the type of things that we're eating or drinking, the medicines that we're taking. Some can be related to different things that have happened in your life, such as giving birth to a child, having just even been pregnant, some sort of injury, trauma, other health conditions. But we can get you back to living a more fulfilling and less bathroom frequented life. So for overactive bladder, we typically have a kind of standard advancement along a pathway as far as the best way to treat things. So the first thing is, we got to actually diagnose you with this. And the first line therapy is always going to be some lifestyle changes. So if you're drinking 8 cups of coffee a day, the first thing I'm going to tell you is maybe you should tone that back a little bit. But oftentimes these things are done in conjunction with one another. So after certain lifestyle changes and conservative measures, there's oral medications that we can try. And if those are ineffective, then there's third line or advanced therapies that we can get into as well. Oftentimes, in full disclosure, for people with severe cases where I see you the first time and I think we're headed towards needing an advanced therapy, insurance companies are almost always going to require you to have tried at least 1 or 2 oral medications. So whenever you're dealing with this, you got to just be patient with our different forms of treatment, because we'll get you there as best as we can, but it does require kind of jumping through some hoops sometimes. So simple solutions for different things in your life can be very beneficial. So obviously with anything in your life, diet and exercise are going to be very important. It could mean as simple as, like I said earlier, drinking less caffeine, maybe fewer carbonated beverages, avoiding spicy foods or other things that might be triggering or inflaming your bladder. And sometimes there's things we can do as far as like kind of retraining your bladder as far as delaying going to the bathroom or sticking to a schedule. There's in some instances, strengthening your pelvic floor muscles repeatedly can also be beneficial in stopping these urges. So a lot of times you're already doing a lot of these things, or have tried this or tried that, and it might not work very well, if at all. So the next step when you typically see a urologist is that you're almost always going to get a trial of some sort of medication. So these oral medications, they have to be taken daily. And for some people, they work great, but they sometimes do have some unpleasant side effects. It can cause dry mouth, dry eyes, constipation, blurry vision. Some of them can raise your blood pressure a little bit. And and there is one recent survey that where almost 3/4 of people who were started on a medication stopped taking it within 6 months. There's another study that looked at a large group of people and looked at how many people stuck with their originally prescribed medication, and it was only about 7 to 10%. So oftentimes we're trying various different things to get you to a point where you're happy. But I would say don't give up after a single trial, because we can often make some big improvements. You know what, I actually, just going back to this, I will also say that some of these medications that you are often required to take by insurance companies before they will pay for this or that. There was a large study funded by the National Institute of Aging and published in the Journal of the American Medical Association, or JAMA, that showed that elderly people, so people in their 80s and above, but also sometimes some people in their 70s, were at a greater risk for developing dementia with taking some of these medications. So I really try to avoid some of these, if at all possible, when it comes to treating this. So when it comes to advanced therapies, this is for the people who these conservative treatments don't work, the medications either don't work, or you've got bad, or they help, but you have bad side effects from them. There's a few different things that can be done. So one thing would be getting injections of Botox into your bladder. Another thing would be something where we're stimulating a nerve down in your ankle. And then the other one thing would be modulating or stimulating nerves coming off of your spinal cord. So the first thing, just to kind of go into what Botox is this is a temporary treatment for these overactive bladder symptoms. It essentially medicine is injected into your bladder through a small little simple procedure. It takes about 10-15 minutes, where we inject this Botox into your bladder. Now, if you think about Botox for wrinkles and stuff, that's where people usually think about it. Essentially, what it's doing is paralyzing the muscle. So what this does is partially paralyze the bladder, so that you eliminate all these haywire signals and symptoms that are going off. Now, there's been a very good study that compared this to these other forms of treatment, and showed that they're pretty comparable as far as decreasing the amount of urgency and decreasing the number of leaks. Now, the one thing the things I will say about Botox is that it doesn't really address this whole bladder-brain communication. It's working to really paralyze and shut down the bladder. And that's what the medications kind of do too. And this is just a more supercharged version of that. So sometimes this works a little bit too well, and people can have a little bit of urinary retention or holding on to the urine after this procedure. It happens for women about 6 to 10% of the time. For men, sometimes can be a little bit higher than that, where you might need a catheter either temporarily while this Botox lasts in your system. Now, typically the Botox lasts about 6 months or so, but sometimes it lasts a little bit less. Sometimes it lasts a little bit longer. But you do need to be retreated for this if it's effective for you. So because of this, there's actually a lot of, about half of people who are started on Botox therapy end up stopping it after a couple of treatments, just because the various things that can that go in, or that are involved with you needing to have a procedure every several months. So another option would be something called peripheral tibial neuromodulation, or PTNM. So essentially what this is, and this is a little picture of it here, it's a little device that stimulates a nerve down at your ankle. And this nerve, called a peripheral tibial nerve, goes and plugs into your spinal cord at the same location as where the nerves for your bladder plug in. And so we don't really know exactly why it works. We just know that it does. And somehow stimulating this nerve can also kind of reset the pathways for the bladder nerves, because it's, again, plugging in at the same place. So this can help. It's probably the least invasive of these options. And it can definitely help with the urgency, frequency, urgent continence. And if done correctly, people can have pretty good results with this. The major downside to this is that it requires it's a huge time commitment. It requires a lot from the patient. So you need to, it's a 30-minute session where you have to go once a week for 12 weeks and get this little simulation. And then afterwards, if it's effective and if it's working, you need a maintenance session that happens about once a month or once every 3-4 weeks. And this is the main reason why a lot of people choose not to do this one, is because of the time commitments involved with this. So the next thing, and kind of some of the focus of this talk would be getting something that's called Sacral Neuromodulation, or interstem, which is the device that's made by Medtronic. So essentially what this does is it's addressing that whole bladder-brain connection, and somehow stimulation of these nerves that go to the bladder work to kind of reconnect the signaling, the talking between the bladder and the brain. A good way of thinking about this is that for you, those of you with a real bad overactive bladder, it's essentially like you and I are just sitting here on this chat, and you're hearing me talk English to you. But then all of a sudden, everybody unmutes themselves, and all of a sudden you have 80 people talking, and we're trying to understand each other. It doesn't really work. So what this device does is it's kind of quieting these other signals, and it's applying a mute button to the rest of the people so you can hear what I'm having to say. So the way that this therapy works is that there is a test that you get first before you get any implants, and we see if it works for you. And for any of these things, we define success as a 50% or greater reduction in your symptoms. So if you're leaking 8 times per day, if the medications aren't effective at all, we can get you down to 4 or less. That's by technical standards a success. So if this therapy is successful and you're happy with it, then we go to a full implant. And these implants, there's 2 different options. One of them is this slightly smaller one, which is the Intercept Micro. This is a rechargeable battery. It lasts longer, so it lasts about 12 to 15 years. And you do have to recharge it periodically, usually about once a week is what we tell people to do. It takes only about 20-30 minutes to recharge it. It's a wireless recharger, kind of like a wireless charger for your phone. And you just hold that over your the implant site. So when we put these implants in, as you can see here, it's kind of on the upper outer portion of your butt. So it's below your belt line and it's above where you sit. So you really shouldn't feel it at all. The slightly bigger one, which we'll be getting smaller with the next generation device, this one lasts about 5 to 7 years. The next generation device, so if you were to get this by the time you needed a replacement, it would last somewhere between 8 to 10. And this thing, you don't have to do any day-to-day maintenance on it. It's in there, it's working, and you just you just set it and forget it. So the first step, like I said, is just getting a test. So depending on, it varies a little bit from patient to patient, but typically what we're doing is a little outpatient procedure, which is done under local anesthesia. There's no need for any anesthetic. You can drive yourself, you can go to work the same day. Essentially what we do is we have you come into our little surgery center and we numb you up kind of on the lower part of your back, and we put these little wires in down to the nerves that go to the bladder. And I'll just go back just to this picture where the nerves that are coming off the spinal cord going down are this lower part of your back. So what we do is we put these wires in and we connect these leads to a little temporary external battery. So this is what it looks like. This person's wearing the belt and the battery fits in this little pouch and it's connected to these leads that are underneath his clothes. So it's worn discreetly. It's in there for 1 week. And then we take them out and we see how you did. And we see if you had a 50% or greater improvement of your symptoms. And if you did and you're happy with it, then we can move forward with just putting a full implant in. It's very simple to do. And you can return to your normal activities really quickly. In about 3 to 14 days, you're back to normal. So the thing that we really like and that I really like about this is that if you start with a Botox and it causes retention or it's not the therapy for you, you basically have to wait a full 9 months until it's completely out of your system before we can do this. So this thing, we do the test 1 week later. If it's working and you want to go forward with the surgery to put it in, great, we do it. If we do the test, it's not really cutting it for you and it's not the surgery for you, then we can say, well, maybe Botox is what you need, and you only lose 1 week of time as opposed to losing out on a full 9 months waiting for the therapy to wear off. So the Intercept device is very safe. It's very effective. It's been around for over 20 years, if you can believe it. But there's been a lot of technical advances recently, especially within the last five years or so. So it has a really high satisfaction rate. About 84% of people who have the device are satisfied with it. It works at least 3 times better from a quality of life standpoint than any of the oral medications. And when we're talking about how many people actually achieve success with this, and again, success we say is 50% or greater improvement of your symptoms. The answer is 76% of people who tried this, it worked, versus 49% for these medications. So there's other analyses that will give you a plus or minus percent on as far as the success rates. But if we are selecting you appropriately, I think in our group, the number of people who actually move on to the full therapy because of carefully selecting the right people is over 90%. So if this therapy is this therapy right for you, that's kind of to be determined. And we're happy to talk to you about this more and to see if this is something that could really help you and improve your life. If you have really significant symptoms, if there are certain people with specific types of urinary retention where this can work. One thing that's not on here that is also really not talked about a lot is if you have something called fecal incontinence, meaning that you are leaking stool and you can't control that. This is actually the only therapy that's approved to treat that. So there's a lot of good reason to try this out if you've tried a bunch of other things that haven't worked in particular. So if this sounds like something you'd want to try, the first step is just to be evaluated, and we're happy to see where things go. So here's just one patient testimonial where people can get back to doing things that they used to do that they couldn't do anymore because of how often they were going to the bathroom. So that's about it. So we're going to open it up to questions. I think there's going to be, I think a lot of people filled out some questions in the chat and on the Q&A, and we'll try to get to some of these here. So I'm gonna stop my screen sharing right now. Okay, I will leave this up. Shauna, are you able to read some of these questions off? I don't want to reveal patients' names.
Yes, yes, absolutely. The first question is, how long has Interstem been around?
Yeah, so like I said, Interstem has been around for over 20 years. It was developed first in 1997 and started doing trials on this, and it's been implanted really since then. Now, there's been a lot of advances in the therapy as far as making sure that the leads and the wires that we put in there don't move and don't have to be revised. And so we've seen the revision rates and the rates of people having pain at the site of the implant go down from, like, I think earlier on that the rates of people having a significant pain that would require us to remove the device was about 30%, and now it's down to less than 5%. Same thing with lead migration, or which would be we put this lead down on the nerve to go to the bladder. So they have tines that help it stay in place, but before they didn't have those things. So now it migrates less than 4% of the time. So these things, once they're in there and they're working, they're working typically.
Okay, next question is when in regards to lifestyle changes. The question is, how much coffee daily is too much coffee?
Well, that's a tricky question. It's not as much the coffee as it is the caffeine, and everybody's going to be different. Some people are going to be way more sensitive than others. So for some people can drink 6 cups of coffee and not really notice anything. For some people, 1 cup of half and half decaf regular coffee is enough to throw their bladder into a tizzy. So there's not necessarily a how much is too much. It's really the amount that causes you personally to need to go to the bathroom more than you would if you weren't drinking it. And with any of these things, we do what we can for you, and then you need to do a little bit of your part too. So if we are putting this therapy in and any of them, either the Botox or the interstem, it's really beneficial if you can cut back on the caffeine or the spicy foods or the carbonated beverages, all these things that can contribute to the bladder symptoms. If you do a combination, harkening back to those lifestyle changes, those are always important things to do, kind of regardless of what we do from our end. Next question.
The next question is, does the Intercept device interact with a Pessary?
No, so it really would have no interaction there. So the Pessary is going to be something that's for women, is put into the vagina to kind of hold up the pelvic organs if you're having prolapse or a dropped uterus or dropped bladder, or that's why that's put in. Now, this is something that goes in your back, and it's very well away from that. So people, it's not usually exclusive things. So women can have prolapse and have overactive bladder. Sometimes fixing the prolapse can help with some of the overactivity, but it's not the only thing. So oftentimes, I have plenty of women who have had either surgical repairs of their bladder or manage it with the pessary, who have also had the interstem or have had Botox or any of these therapy options. Next question.
Okay, another question. This person says they urinate frequently at night and it affects their sleep. Experiences no problems during the day, but at nighttime is an issue. What can they do, and will interstem work for them?
So that is a tricky question. So sometimes the answer to that is yes, the interstem could work well. Now the problem really comes from insurance companies and what they will approve and pay for. So sometimes if we've kind of exhausted every other option, we can get that through if we give you a test and it ends up working. Now, some of the first things that I would say for waking up at night would be, if that's the only symptom, would be number one, making sure you're not drinking a ton of fluids at night, because that's the first thing we do, is try to cut back on fluids in the evening to see if that helps. Sometimes taking one of these medications at night can be beneficial to kind of slow that down a little bit. And one of the things that we actually see quite a bit of is people who have sleep apnea, which is particularly people who are snorers. So if you snore a lot at night, or if your partner snores at night and they're getting up to pee a lot, essentially what happens when you have sleep apnea is that you kind of catch your breath, the pressure in your lungs builds up, and your heart senses that pressure buildup and releases a hormone because it thinks that you've got a bunch of excess fluid in your body. So your heart releases a hormone that acts as a diuretic and causes you to make more urine at night. So sometimes if the answer is that you're waking up at night because you have undiagnosed or untreated sleep apnea, sometimes treatment of that alone is enough to completely fix your nighttime waking up. Now, sometimes if we kind of exhaust everything and we tried everything and we give you a trial of the interstem, I do have some patients who that's worked for. We basically have to convince the insurance companies that, hey, we've tried everything else and this is the only thing that's helped. And we can often get that through, but it's the nighttime waking up is not one of the criteria that a lot of the insurance companies use to approve the full implant. So that's a kind of a roundabout answer for you, but just to kind of sum it up, the answer is possibly this is something that could help, but we'd have to try a bunch of other stuff first. All right, next question.
Does the interstem only decrease 50% of the leaks, and that is considered a successful trial?
So the interstem will oftentimes work much better than that. We say 50% because that's where it's approved for implantation, and that's where we hope to get you is better than 50%. Now, there are some people who have this, maybe about a quarter of people who have their interstem put in where they have basically 100% improvement of their symptoms. There's probably about 40 to 50% of people will have a 75% improvement. And then when we go to that 50% cutoff, that's where we get to like that 76%. So not everybody gets to 100%. Some people do, but for a lot of people, if you're leaking more than 5 times a day because you can't make it to the bathroom on time, if you can cut that down to 1, that would have a tremendous impact on your quality of life. So, or even if you cut it down to 2. So we really try to get 50% or better, and we keep track of these numbers so you can be aware of where things stand. But the goal is 50%, but a lot of times we see much better than that. Sean, are you there? You might be muted.
Yeah, sorry, the internet it's been going in and out. So the next question is, how do symptoms of overactive bladder differ from an enlarged prostate? And can it be a result of an enlarged prostate?
All right, so that's a very good question. So the answer is to the second part is yes. For the first part, so usually symptoms of an enlarged prostate, the most common symptoms that we see are a weak urinary stream. So this is for the men. So all the ladies listening, you don't have a prostate, so you don't have to worry about this. But for the men, an enlarged prostate is something that happens naturally to all men as we get older. So as we get older, our prostates get bigger. That's part of life. And now it's going to affect different people in different ways. And typically what you're going to see is that your stream's going to get a little bit weaker. You might have a little bit of starting and stopping. It might take you a little while to get started. Sometimes you don't feel like you really empty all the way, or you have to kind of strain and push. Now, sometimes if you're not really emptying your bladder all the way, what happens is that you have a lot of this urinary frequency and urgency because your bladder is always partly full. So if the prostate's the issue, for men, we got to treat that first. We need to make sure that the prostate's not blocking things off, that you're emptying your bladder okay. And if we can tell that you are, in fact, completely emptying your bladder or emptying your bladder enough to be normal, then we can say that, hey, probably it is a little bit of overactive bladder too. So sometimes what can happen is for men, typically these weak stream symptoms will start first in life at some point where you're having to strain a little bit more to pee. And over time, and when I say time, I mean years, what can happen is the bladder develops these changes within it to have to squeeze harder to empty against the resistance of a big prostate. And so some of these changes over time can result in connective tissue, so not non-muscle tissue being in the muscle wall of the bladder. And that can lead to some of these weird pathways and these weird nerve signaling things things that happen where it can lead to overactive bladder. So that's why we see overactive bladder tends to affect women earlier in life than men. Men typically are going to be affected in their 50s and 60s at the earliest. Women can be in their 30s and 40s. A lot of the time, what we have to do is make sure the prostate's not an issue. And then once the prostate is addressed, then we can work on all these other symptoms of overactivity of the bladder. So there are plenty of men who are on medications for the prostate and who have had these various therapies too. So sometimes it's both a prostate issue and a bladder issue. You can think of it as from a plumbing standpoint, it's a outflow issue and then also a storage issue. So there's two different things going on. All right, next question.
The next question is, you mentioned carbonated beverages earlier. Does that include sparkling water? And yeah, sparkling water.
I would say yes. And again, this is all within moderation. So, certain things are going to be worse for the bladder than others. Carbonation is not as bad as caffeine. Caffeine is the big one that a lot of people don't realize how much they're drinking on a day-to-day basis, and the thing that really affects the bladder a lot more. But there are certainly a number of different things that we can see for this. We always tell people to avoid different things when it comes to their bladder. So we say like avoid some of the C's. So avoid carbonation, avoid caffeine, avoid, I call it capsaicin or spiciness. There's a various number of things, and so the answer to any of these lifestyle changes is that it's always within moderation, and it's what affects you may not affect the next person. What affects one person greatly might not have any effect on you whatsoever. So I don't want you to not enjoy things in your life that give you pleasure, and if drinking LaCroix, even though it doesn't taste like much of anything, even if you like it, then by all means, please, drink it, but just know that sometimes that might affect your bladder. And so it's all quality of life, and it's all about balance and reason.
Okay, next question. Do you have all of these options available in the urology group, Northern Kentucky?
So I believe so. So certainly Botox is available. There are people who do the PTNS, which is the nerve stimulation in your ankle. At our Northern Kentucky office there, we do that out. As far as providers down in Northern Kentucky who do the interstem, there's one person, Dr. Shea, who does that. He doesn't do as many as I do, or as some of my other partners do. And if you wanted to see me or see one of my partners who does more of these implants, we do have offices in Norwood, so that would be the closest thing. So you wouldn't have to drive up to Blue Ash or to the west side. So if there's anybody out there who's in Northern Kentucky who wants to see me but doesn't want to go to Blue Ash, you can make an appointment with me on Thursday afternoons. I'm in Norwood. Next question.
Okay, will any of these options help spastic bladder in men?
So it kind of depends. So oftentimes when we hear spastic bladder, so without getting more information from this individual patient, a lot of times if it's a spastic bladder where your bladder is just not really squeezing, or is just really has the inability to hold urine, and store urine safely because the pressures are just really high in the bladder. Oftentimes Botox is a better option for that. But it's on an individual basis. We'd have to do a full workup and see. Sometimes sometimes the interstem can actually work pretty well for that, but that would be on a individual basis. We'd have to make those determinations. So I can't say for sure just based on that question, but I'd be happy to discuss that with whoever asked that. I'd be happy to see you and talk about that. All right, next question.
Could a change in medication for an enlarged prostate be a cause for OAB?
Not necessarily. I mean, oftentimes if you're changing medications around, it's because we're trying to get you emptying your bladder better. And then kind of coincidentally, as you're dealing with this big enlarged prostate, your bladder is continuing to change and having to work really hard to overcome peeing past your prostate. So usually the medication changes from a prostate standpoint shouldn't result in OAB. It's going to be something that's kind of developing on its own. And sometimes, depending on whether or not you're on some of these medications, it can kind of help reveal some of these symptoms, but none of those medications by themselves will cause anything. Okay, next question.
Okay, next question. Will the interstem interfere with a pacemaker?
No, that's a good question. So, and I'll kind of add some new information on top of that. So you can think of the interstem almost like a pacemaker for your bladder. That's what it's doing. It's regulating these nerve signals, and it's kind of in there just doing its thing and working. So there is no interference with a pacemaker. In fact, there's some people who have spinal cord stimulators or pain stimulators that we have there. We have the interstem on one side of their buttocks, the pain stimulator on the other side. So it's a lot closer than where a pacemaker would be, and there's no interference. The other thing that I will say that I didn't bring up in the talk is that MRI compatibility has been an important change in these devices that's happened very recently. So these devices are compatible with a full body MRI. So if you had any reason to get an MRI, either like an injury or now for people with multiple sclerosis, or if somebody has a head injury or something, anything that happens where you might need an MRI, you can get that without any problems with this implant, which is a very positive change. And that's new within the last couple of years here that's been available. So yes, this device is completely compatible with the pacemaker. It's compatible with pain pumps or other pain stimulators. It's compatible with MRIs. You can get CT scans. It's really compatible with anything medically. Now you might have to turn the device off while you get a scan, but that's a minor thing, and that doesn't really impact anything whatsoever. A very good question. Next question.
Okay, next question. How effective are Kegel exercises to build pelvic floor muscles?
So they are, I'll say they are always effective. Now, some people, the effectiveness might be limited, and even if you get you strengthen your pelvic floor muscles, especially if you have stress incontinence where you're leaking because coughing, sneezing, if sometimes those Kegel exercises don't really work. And when we do talk about Kegel exercises for these for overactive bladder, a lot of times what we're trying to do is teach you to do these exercises when you have these urges coming on, so that you can kind of distract your bladder and maybe hold the urine a little bit better. So for overactive bladder, it's kind of a strategy that you can use to help you get to the bathroom on time. It's not necessarily for prevention. For stress incontinence for women or for men who have had their prostate removed, that's something that can be done to really strengthen things to be able to hold your urine better and prevent stress incontinence. And oftentimes that is pretty effective. Sometimes we have you see a pelvic floor physical therapist, somebody who can teach you more effective ways of doing those exercises, or sometimes you can just do it on your own at home and watch a YouTube video or something like that. But for overactive bladder, again, it's mostly I have people do that so that they can kind of distract their bladder so that they can make it to the bathroom on time. It's not so much to prevent any overactive bladder issues. Our next question.
We just, looks like just a few more questions left. What is the best option or treatment for leaking due to a prostatectomy?
So the interstem, this device is not going to work for that. And the Botox probably won't work for that either. So that for those of you in the audience here who have had a prostate removed, who have continued leaking with coughing, sneezing, or just kind of like a slow drip that comes out, doing those kegel exercises that I just talked about is the first thing that we have you do. And if that doesn't really work, there's a couple options. One would be to put a little male sling in place, which is something that is basically we put a little kink surgically in your urethra, so you leak a little bit less. That's kind of fallen out of favor, and the main thing that's done is something that's called an artificial urinary sphincter. It's an implant where it's basically a cuff that sits around your urethra that holds it closed. And when it's time to go pee, you press a little button that sits inside your scrotum, and you pump it up to open up that valve and open up the urethra, and then you go to the bathroom, and then it automatically refills, and then you go back to being continent. That's not something that I do. I have multiple partners who do that. So if you have a question about that, you can always talk to the provider that you see, or send a message about seeing somebody to talk about that artificial sphincter. And that is something that has a satisfaction rate that's off the charts. It's like over 95% of guys who have that love it. And even if it gets infected and needs to come out or needs a replacement or revision, people still would recommend it because of the quality of life. So if you're in if you're in those shoes where you're having leakage after a prostatectomy, because that type of leakage, the stress incontinence, the leaking with coughing, sneezing, etc., talk to whoever your urologist is about an artificial sphincter, and I think you'd have pretty dang good results. 2 more questions.
Okay, so does Medicare cover the interstem system?
Yes. So it is, once we get you through the requirements, it's fully covered. So again, depending on your exact plan, either with Medicare or with private insurances, you oftentimes have to try 2 of those medications first. And as soon as we establish that the medications aren't working, then they will approve it and pay for it completely.
Okay, last question. This patient has been to the urology group, but has always just seen a physician's assistant. How can they make an appointment with a doctor?
So that's why we're here. And so what I would do is I would encourage you to call the number that's on the screen right there, the 841-7800, and just ask if you can make an appointment with either me or with somebody who treats whatever is going on for you. So if you're here because you got all this leakage of urine and you want to talk about some of these other options, just call and say, hey, I've been having issues with incontinence. I've seen whichever physician assistant, and I'd like to see the doctor. I'd like to see Dr. Szabo, or I'd like to see somebody, whoever it is it's closer. If it's closer to you, on the west side, we have doctors who see people on the west side. If it's Northern Kentucky or east side, we have people over there too. Just give the office a call and say, hey, I want to see a doc who does this. I've seen a PA and I'd like to see a doctor. Just call and we'll make that happen. And then also, the last thing I'll say here before we end the talk is that you should be receiving an email after this with a follow-up information from Medtronic. We have a number of really great, awesome Medtronic reps who are incredibly helpful throughout the whole process when it comes to these interstem devices. And so they will follow up with you and can get you in contact with me or whoever it is that's in the office close to you to get you plugged in with somebody that can take care of you. And again, I really appreciate everybody who joined the chat. I'm glad I could reach out to however many of you were here today. And again, the big thing is that you don't necessarily have to live with this. There's a lot of things that we can do. There's a lot of things that can make your quality of life better. And not every therapy is going to be the right therapy for everybody, but I really encourage you to come talk to us. And I personally, and I know that all my partners are more than happy to help you and try to get you doing a whole lot better and live your life to its fullest. So thank you very much. It's been great talking to you guys, and I hope to see some of you in my office.
Great. Thank you so much, Dr. Szabo. Just to remind everyone still on the call that you can contact the Medtronic rep in the email that will be coming out to you tomorrow. Just respond back if you have any further questions. Otherwise, when you call and to make an appointment, just make sure that you include that you viewed this presentation and you would like to schedule an appointment to talk to someone further about overactive bladder. Thanks again for joining tonight. Have a good rest of your evening.